I think in 2020, we made a lot of progress in colon cancer in terms of the personalized medicine. I think we are in a sort of era of what you call a molecular revolution. In 2020, and all the patients who was diagnosed with stage 4 colorectal cancer should get NGS or molecular profiling done at the beginning, especially in stage 4 patients. Now, there's always controversy about stage 2 and 3 patients. There are certain, I think, biomarkers that has to be tested, such as MSI status or MMR status, because that will help dictate, especially in stage 2 patients, whether they should get adjuvant chemotherapy or not. However, other profiling of the in stage 2 and 3 patients, we don't know exactly what to do with them. So other than trial basis, I would recommend at least minimum testing MSI high status, MSI status, MMR status, and BRAF status for Lynch syndrome. However, in stage 4 patient, it is a little bit different. We have many actionable mutations that exist in colon cancer that can help us personalize those patients. For example, the KRAS, the BRAF mutation, MSI status, the HER2 status. Those are some of the profiling that's available that we can potentially use at the beginning to dictate the treatment of the patients. Now, some of the challenges that we face with this is in a couple of folds. Number one is that ideally, when we start somebody with chemotherapy as a first line, we would like to have this profiling available at the beginning. However, unfortunately, most of the time, the tissues are outside. By the time we get the tissue, we send it out for NGS profiling. It takes about 4 to 6 weeks, and most of the patients do not want to wait 4 to 6 weeks to get treated. Therefore, in those settings, we would start a patient on chemotherapy without the profiling being available. So that's one of the challenges we have to overcome. Second thing is that there are several actionable mutations. However, if you look at the whole profiling panel, it's usually 200 to anywhere to 50 gene panels. Most are not actionable, but those can pick up some of the rare fusions. Question is, at the beginning, should we do what we call a selective testing versus a whole panel testing? And that's still controversial at this time. Personally, I would like to get the whole panel because at the end, when you do a selected panel, I may run out of tissue to run at the end when they fail first-line therapy. Therefore, ideally, I'd like to get the whole panel at the beginning. And this is where I think a liquid biopsy will come to play in the future, because it's much easier to get, it's easier accessible, and hopefully the turnaround time with liquid biopsy is only 7 to 10 days. In colon cancer, there are many biomarkers that are prognostic and that are predictive. Recently, based on the CLGB SWOG 804-5 study, there was a full mutation analysis that was presented last year. And when you look at that data, some of the facts we knew already. So what are the prognostic markers in colon cancer? In that study, the patient with BRAF mutant tumor had overall survival up to 12 to 13 months. So we know that BRAF is a poor prognostic marker. They also, in that study, found that the patient with RAS mutations also had a poor prognosis. Their overall survival is only 25 to 27 months. So the best patient with the best phenotype are what we call a triple wild type. So KRAS wild type, NRAS wild type, BRAF wild type. Those are the patients that really had a very good outcome. And in that study, they also looked at tumor mutation burden, what we call TMB. And this is the first study that looked at this as a prognostic marker. And what they found is that patients with high TMB had a better prognosis. And this makes sense because patients with high TMB colon cancer, they tend to have high levels of neoantigens, which means that there's more tumor infiltrate lymphocytes, which means that their immune system is intact, so able to control the cancer in a much better way. Now, in terms of the predictive biomarkers, we know there are many predictive biomarkers that we use currently, such as the KRAS status, such as the BRAF status, such as the HER2 status that we're used. And for immunotherapy, we do use MSI high and MMR status for it. And also, very rarely, we do use track fusion as well, because now there are drugs that are able to target those. And in that study, patients who were MSI high, interestingly enough, they responded better with the bevacizumab arm base compared to cetuximab arm base. And that makes sense because most of the tumor that MSI high are in the right-sided tumor. And we know the right-sided tumor tend not to respond to EGFR inhibitor.